Welcome, colleagues. We'll just give another minute for those that are joining. Thanks to the speakers. I see you all here. Good to see you. So it's 1 minute after, and I think I'm going to kickstart the session today. Hi, everyone. My name's Tamara Credo. I'm based in Cape Town, South Africa, and I'm very, very pleased to be moderating the session today. We have a great lineup of speakers, and I'm going to introduce them shortly. And welcome to all of you. It's wonderful to have all of you that have joined the session today. I think this is an incredibly important webinar, particularly in the context of COVID. We're talking about guideline adaptation, but really it's applicable way beyond COVID to so many areas of the work that we do. So just to kickstart us, I wanted to say that this session has been organized and convened by the GIN Low Middle Income Country Setting Working Group and the GIN Africa community. And the webinar is called Global Guidance and Local Application During the COVID-19 Pandemic, Best Practice for Adaptation of Guidelines. Let me introduce you a little bit to what will be happening during the webinar today. Perhaps some of you have been part of the other GIN webinars in previous sessions, but if not, we want to welcome you for this session and to remind you that GIN is running a series of COVID-related webinars. And thanks so much for joining today. The idea is that this is a learning opportunity. We have speakers with a wealth of experience, but actually I'm sure in the room there are also other experiences that we would love to hear about. So there will be an opportunity to participate in different ways in the session. As the speakers speak, we will give them a chance to finish their presentation, but there'll be a chance for you to either enter a question into the question box that you have available to you, or you can raise your hand. I'll be able to unmute you. At the moment, you're all in listen mode, so you should only be able to hear us, and you won't be able to speak, but I can unmute you, so we'd love to hear what people have to say. So as it outlines there's the questions panel, raise your hand. We will be recording the session because all of these sessions are made available on the GIN website. Just a bit of background. So GIN, the vision is trustworthy, accessible guidance for better health. And the mission is to lead, strengthen, and support collaboration and work within the guideline development, adaptation, and implementation community. GIN provides a network and partnerships. It assists members in reducing duplication of efforts, and it promotes best practice through development of opportunities for learning and building capacity. Today's session is specifically about global guidance. So we have evidence coming from a global setting and guidelines coming from many settings, but it's about local application of those guidelines, particularly in the context of COVID. This webinar is for policymakers, guideline developers, researchers, the public, and anyone involved in decision making, not only in low income settings, but in any setting where you're trying to avoid duplication and waste of resources. But of course, particularly for places where we can't afford to be doing systematic reviews from scratch when there are so many already out there, or guidelines from scratch, when we can be learning from other guidelines that are available. So there'll be a few case studies shared from colleagues, and I'll introduce you to the colleagues that will be on the call. So very happy to introduce my speakers. Maybe you can wave when I mention your name. So this is Dr. Joseph Matthew, who's a pediatric pulmonologist in India, And he has been a leader in evidence-based medicine for many years, involved with the South Asian Cochrane Network. Of course, that is Cochrane India now. He's also a member of the GIN board, a trustee on the GIN board, and he's chair of the GIN LMIC working group. I'll just put up declarations of interest so that everyone can see those as we go. But welcome to Dr. Matthew. Thank you so much for your time today. I'd then like to welcome Tamara Lotfi, who will be speaking next, who is a research associate who's from Beirut, but is currently working at McMaster on a very exciting project amongst many projects. But she's well versed in the field of evidence-based healthcare, systematic review methods, and is involved in the leadership of a guideline project that she'll share with you today. Welcome, Tamara. I'm also delighted to introduce Ajibola Awatiwan, who is based in Cape Town. Good to have you here. And he has been leading the adaptation contextualization of WHO-aligned clinical guidelines in Ethiopia and Nigeria, which is the project he'll be telling us a little bit more about later. But generally speaking, he works in the knowledge translation unit at the University of Cape Town, where they develop a number of primary care guidelines and clinical decision aids and implement them in large, very impressive pragmatic clinical trials. And he is one of the colleagues working in that unit, conducting reviews and supporting the evidence base and implementation of these guidelines. Thank you, Ajibola. And of course, our colleague, Dr. Patrick Okwin, who's calling in from his solar-powered connection in Bamenda in Cameroon. He's a clinician, he's a district medical officer and team lead at eBase, and he juggles his clinical work with this work around leading research, getting research evidence into practice with a focus on clinical practice guidelines. And as you'll see, he's also a member of the GIN Board of Trustees. He's involved with the Africa Evidence Network, Joanna Briggs Fellow, and the team lead at eBase, amongst many of his other involvements. And his declarations are up over there. So a big welcome to Patrick. Thank you very much. Just to remind, welcome, it's that GIN has got a number of COVID-19 resources, and we welcome everyone to visit the website. Many of you may know that GIN holds a large database of guidelines, so that's already a fantastic resource. But through COVID, they've been creating extra collections of information that would be relevant for many policymakers, clinicians, and the public. So we welcome you to go and visit those spaces. Great. So I'm going to start. I'm just going to remind our speakers that all of us will be muted and we'll switch our cameras off while someone else is speaking. So I'm going to switch myself off now, and we'll hand over very shortly to Dr. Matthew to take us forward.
Thanks very much, Tamara. So good afternoon to everyone, or good morning, or good evening, as the case may be. So to kickstart this, I'm going to make a small presentation called COVID-19 Guidelines in the context of resource-constrained settings. And to start with, I'd like to remind everyone that resource constraint doesn't only mean poor countries or financially impoverished settings, but it could be also resource constraints in terms of deficiency of empowered human resource, material resource, and of course the financial resources. So resource constraint is a broad term, and the developing countries of the world, which comprise 85% of the world's population, usually have constraints in all of the three resources that I just mentioned about. Now it's important to understand how these settings actually function in order to learn how guidelines work in the context that we're talking about. Tamara, have you handed over to me to move the slides? Yeah, that's great. So the first part I would like to cover is the healthcare system in the context of resource constraint settings. This is important to understand because then we can make out why and how these guidelines operate. Now, by and large, all these resource constraint settings have a complex healthcare delivery system which comprises multiple healthcare delivery modes. There's usually a public sector jostling with the private sector. Both of these sectors have for-profit and not-for-profit institutions. Then there is state level, regional level, trusts, and things like that. And to complicate things further, there is a tertiary hierarchy with a primary level care, secondary care, and tertiary care. All of this looks very nice and pyramidal on the chart, but there is usually no well-defined referral system, and people can access any of these multiple delivery modes as and when they please. So that creates a layer of complexity, which is not so common in the developed countries. Now, there is within these multiple healthcare systems also multiple settings to deliver healthcare. So if you look at this colorful slide, the top two pictures on the top row actually represent a healthcare delivery of antenatal care in what is called a small rural tribal hospital setting. So this is pretty much what they can do. They sit under a tree and maybe check the blood pressure and things. Contrast this with the lower two pictures, which represents a tertiary level city-based high-tech hospital in which you can get the state-of-the-art healthcare in terms of services, which are probably at par or even better than some of those in the developed countries. Now, an individual citizen of countries in these developing world can access any of these healthcare systems, and his access is usually decided by what he can afford and what is available within his reach geographically. The third nuance is the paucity of delivery standards, in the sense that most of these healthcare systems in our countries don't have well-defined delivery standards. And this chart, which you should not try to read, is basically from the health and safety and quality standards from an Australian setting. It's just to show the enormous extent of depth to which they go to make sure that a certain quality is met with each of their institutions. Now, this kind of quality setting is lacking in most developing country hospitals and institutions across the world. And then, of course, most developing country or resource constrained settings have this provider-driven or provider-centric approach in which the healthcare system is primary, not the consumer or the patient or the user. So, and very often it's a take it or a leave it kind of a situation, and people have not really got choice in sharing the decision making as we would expect in an evidence-based shared decision making model. We also have in most of these countries and systems multiple healthcare healing paradigms, by which I mean that it's not just the usual Western system of medicine that we are familiar with, which operate in these countries. There are alternate systems of medicine, traditional systems of medicine, faith healing based systems of medicine, and also indigenous systems of medicine. And a lot of these don't have a robust evidence base, and they compete or they work side by side with the traditional systems of medicine or healthcare delivery, and people can choose one or more of this at the same time, and sometimes they kind of are contradictory to each other. And this is common in most of the developing countries of the world. Now, against this background of the healthcare system that I've tried to describe comes this challenge of COVID-19. And COVID-19 has posed some unique opportunities in the sense that the disease seems to behave more or less the same way across the developed and the developing countries. But how do we develop guidelines in the settings that I'm talking about in the previous slides to make this a useful kind of a process? Now, the big challenges are that most developing countries and resource constrained settings are struggling to develop guidelines for their own local context. But in most of these settings, the guideline itself is an administrative document rather than a scientific document. So it serves to tell the users or consumers, do this or don't do that, rather than a scientific process to inform or educate. And that's important because guidelines are not rules by themselves. They're actually designed to help inform and educate on what could be done, on what could be delivering the best results. But in our countries and systems, most of these are administrative documents, sometimes linked to financial issues like what can be paid for and what cannot be paid for, but they're almost always administrative rather than scientific. In the smattering of guidelines, which are actually of some scientific origin, most of them are developed through a process of consensus, and I've abbreviated this as curse of the consensus. Now, in theory, a consensus document looks good because it means a lot of people have signed up to say the same thing. But in practice, what happens is what is shown in this picture over here. One or two people dominate the room, and what they decide to say then becomes a consensus statement by virtue of the fact that the rest don't have anything to offer in contradiction. So a consensus is carried by the fact that there was no opposition to this. So most of the documents which you see in COVID-19 guidelines from developing countries and also for non-COVID-19 guidelines would have this phrase called consensus statement or a consensus recommendation rather than a truly evidence-based document. We also have the COVID-19 posing this sense of urgency. The way the dynamics of the disease have been, everyone wants guidelines developed yesterday and not just today. So most of our countries are falling over themselves trying to offer quick fix solutions. And in the process, sometimes evidence is missed, evidence is relegated to the background. And a lot of our guidelines are developed without even looking at the evidence, sometimes to just keep up with what is happening in the rest of the world. Most resource constrained settings are encumbered by influences and pressures from outside and from within. We have international pressure because in the context of pandemic situation, what works in one country or what is done in one country can severely impact the rest of the world. So most developing countries are under pressure from the rest of the world to make sure that the systems are robust and up to date. And that creates a level of nuance which is not common for diseases which are not pandemic in origin. And internally, there are pressures in terms of, political pressures of the governments trying to do some things which make them look good and at the same time protect the people. There is also pressure from the media, there are pressures from advocacy groups, and there's also pressures from consumer groups. So the decision-making process is not entirely based on science and evidence alone. It might be influenced by a lot of these external and internal pressures. Another complexity is that some countries and settings which try to transplant a guideline which is developed and designed for another setting is sometimes faced with this odd challenge of what happens when we transplant organs, and that is the local system of the human being kicks in to reject the transplanted organ. And so sometimes transferring a guideline which has been developed for another setting in another context, even if it's for the same healthcare problem or the same healthcare issue, can result in trying to push a square peg into a round hole, and we know that that creates a lot of difficulties. The weak thing, I think, in settings like ours in the developing world is not just the lack of guidelines which are based on evidence, but also the lack of implementation of these guidelines. And this picture shows you the context in my own country, wherein there's not just a guideline, but there is a robust legislation which says that people driving bikes are supposed to wear helmets. The guideline is there, the legislation is there, everything is in place, but what is lacking is the implementation of that guideline. So the implementation of wearing helmets is weak. The implementation of penalizing the people who don't wear helmets is weaker still. So what happens is that you've got a document, you've got a policy, you've got a framework, you've got a legislation or a guideline, but what is lacking is the implementation of that in letter and in spirit. So coming back to the context of this evening's or this afternoon's discussion, what then can developing countries or resource limited settings do to move forward from this kind of difficult situation that we're in? So we have basically three options. The first is to reinvent the wheel, which means to try and develop guidelines de novo. And believe me, most developing countries or resource limited settings are struggling to develop de novo guidelines, looking at their evidence, trying to do this very fast. But in the context that we're in, the resource development, the resource constraints will not allow de novo guidelines to develop from scratch. So I think we'd end up with what's happening in this picture. Trying to do that would probably make the wheel crush the person who's trying to do it. But that is one option for settings which can do that. Another option is in this next slide, which is to copy paste. By copy paste, I mean adopt. So there is a guideline, say, which has been developed for an entirely different setting, or the WHO has released a guideline. You try and transplant or adopt that as it is, copy and paste it in your setting, as this picture shows. Sometimes that would work, sometimes that might not work, because what works in a given setting depends a lot on the local setting itself. The third option is what I've shown in this slide, which is a nip and tuck exercise. By nip and tuck, I mean to adapt a guideline, tweak it, mold it, bend it, hammer it, so that it tends to suit the local setting or the context better than the setting for which it was designed. But the guideline remains basically the same. And you know that nip and tuck operations can sometimes go wrong, sometimes they do well. So in the context of guideline adaptation, there is a lot of tools which can help to adapt guidelines to a particular setting. And these days we use the phrase adolopment, which is a combination of adaptation and development de novo, and the mixture can sometimes work in settings like ours as well. But I would like to propose here an entirely different approach, which is not to try to develop a guideline de novo, not to try to copy paste a guideline in our local setting, not even to try to adapt, but to look at global guidelines which are based on best quality evidence. And there is a plethora of them available all over the world, freely accessible through the COVID pandemic resources which have been created. But try and see why or why not we can implement them locally. So I'm trying to say here that we look at best practice guidelines, we look at the recommendations from these guidelines, and resource constrained settings spend a lot of time trying to figure out whether or not we can implement them locally, and if not, why not, what needs to change in the local system, and if yes, then why don't we implement it as it is? Because ultimately, I think the focus of all that we're trying to say here is we have a plethora of well-developed evidence-based guidelines. We don't need to reinvent the wheel and develop guidelines again. We might need to tweak a little bit here and there. But the key thing is to implement those guidelines so that we can tackle COVID in a much more scientific and robust evidence-based fashion. I think if we were just focusing on making the guidelines, whether it's through development de novo or adaptation or adoption even, but failing to make sure that these well-developed guidelines are implemented in the local context, then we would be like building this bridge, which is halfway there, doesn't really benefit anyone because we still don't get the best evidence-based practice into the local healthcare systems. So on that note, I leave you with this thought and hand over back to our organizing chairperson, Tamara, to take this forward to the next presentation. Thank you very much for your attention.
Thank you so much for a thought-provoking presentation. And I'm just checking if there are any questions or any hands raised. So I'll just ask my co-organizers if they're seeing anything to alert me to that. And thank you again for that very thought-provoking presentation. And I think it leads very well, as you've provided the context, this leads very well into our next presentation, which is from Tamara Lotfi, who's developing a resource that enables this process of guideline adaptation. So thank you very much, and I'll hand over to Tamara shortly. I see there might be some, I'm not sure if there's a particular, if there is a hand up for any qualifying questions. Okay, I don't see so right now. Okay, so let me hand over in a moment to the other Tamara. One moment. Almost. Over to you.
Thank you, Tamara, and thank you everyone who has contributed to organizing this webinar today. I'm very excited, especially that I see a lot of attendees that have shared with us many webinars in different situations. And just as a disclaimer, I'm very aware that many of the attendees have actually contributed to the work that I'll be presenting and have potentially more experience. So thank you again for the opportunity to present. I won't take too much time with the introduction. I'll just say that the presentation today that I'll give aims to tries to answer the urgent need for contextualization of COVID-19 recommendations. And I think there's a small lapse with the slides. Thank you. And so just to put everyone in context, for those who are familiar with the GREAT approach, it's one of the approaches where we work our way from a question to evidence and then to decision making. And this is mainly the theme of what I'll be talking about today. And I'll start with talking about the GREAT approach in guideline development. As you know, for many of you who are aware of what this approach is, for those who are new to this approach, a GRADE approach aims to provide an important set of details that are critical to the development of a guideline. It has a rigorous methodology that's been well described in a series of papers in the Journal of Clinical Epidemiology and other places that we'd be happy to share the resources to. And it's mainly about focusing on how to move from a PICO question, the main research question that includes the components of the population, the intervention, the comparison, and the outcome, and getting all the way through a long, very important process to a decision that has considered different factors and that has engaged as many stakeholders as possible to have an inclusive decision at the end. And so it's mainly, the GRADE approach is mainly split into two steps. The first one where the focus is to synthesize evidence, and the second one about making the decisions and recommendations. And as you see in the center, we have a panel that provides input and that makes the final decision to answer a certain research question or a practice question. And so here I'm showing the diagram that kind of summarizes the guideline development, and this is based on the Jin McMaster checklist for guideline development. And just to say that the guideline development process is a process that starts from priority setting all the way to updating a guideline. And the GRADE approach provides methods and primarily that helps us know how to conduct the steps of developing the different components that are needed in order to get to a decision that could go to practice, that can be implemented, because it takes into consideration different factors. And so in order to work on what kind of factors should be taken into consideration when developing a decision and when assessing the evidence that exists, the GRADE evidence to decision framework, something that many of you are probably very familiar with, and it includes all the factors that are important, and usually before the guideline development process takes place, we have methodologists who address these different factors through capturing or developing evidence synthesis products. And just to take you through these, and I'm sure many of you, even if you haven't used the ETDs before, have probably considered or actually encountered many of these factors in your daily practice. And not only in clinical practice, that is, in many decision-making situations and practice-related situations, you would definitely have considered whether the problem at place is important or not. Sometimes a problem is more important than the other, and that's why it's more prioritized to actually address it and get to a solution for decision makers as soon as possible. And a problem could be considered important based on the burden of disease, the prevalence, and the baseline risk. And here it's very important to consider this, as today's topic is about contextualization. Baseline risk could be a main factor that affects the contextualization and changes the direction of a practice statement of a decision between two countries in different contexts. Another factor would be values and preferences, and this describes how important the health outcomes, and this is very important to focus on the health outcomes. How important are the health outcomes affected, how to describe them, and how they would vary, and whether there is any uncertainty about it. Values and preferences help us understand the users, the end users, how the end users would value an intervention based on the modification on the health outcome that it could portray. And I'm sorry I'm repeating this, but it's very important. And then the third factor is the certainty of the evidence. The higher the certainty in the evidence, the more likely is a strong recommendation. And in our current context with COVID, we are faced with decisions where we do not have a high certainty of the evidence. We are faced with whatever we have at the moment because the matter is very urgent. So we don't have to have a high certainty of the evidence in order to make a decision. GRADE has many papers that describe what kind of recommendations can be of low certainty, but still, if it is urgent and important to make a decision, we'd still be able to make a decision. But health benefits and harms and burden and their balance. This requires an evaluation of the absolute effects of both the benefits and the harms. And so when we come to a decision maker, to a policymaker, to a consumer, anyone who would be affected by a decision, they want to know why a certain intervention was chosen against the other, as we all know in our practice. And the benefits and harms are the balance between benefits and harms, and making sure that we know that we're making the decision that shows that the benefits outweigh the harms is very important to be portrayed. The resource implications, another main factor for contextualization. This describes how resource intense resource intense an option, if it is cost effective, if there is incremental benefit. The more advantages or clear disadvantages these resource implications are, the more likely is a stronger recommendation. Equity, the greater likelihood to reduce inequities or increase equity, and the more accessible an option is, the more likely it is a strong recommendation. And here I could simply bring up the masks and asking everyone to wear masks and resources in settings where some populations do not have access to masks, and some populations cannot afford reusable masks, and are not aware of the importance of cloth masks, for example. And then we move to acceptability. With the greater acceptability of an option to all or most stakeholders, the more likely a strong recommendation is. This is another main factor that, for contextualization purposes, needs to be addressed. And maybe, and I link here to what Joseph was talking about, that adultment is important. I'll go back to adultment later in my slides, but some factors will vary between contexts, and some factors would have more importance in different contexts. And that's why so far, I hope that all of you see the importance of these factors put together before making a decision. And the last factor I'll bring up here from the ETDs is the feasibility, where the greater the acceptability of an option to, I think there's a mistake here in the slide, I'll share new slides, but feasibility, the more the intervention is feasible, the more it is successful, and the more we are actually reaching the health target that we are planning to reach. So just to summarize the details, the reason why we're trying to talk about ETDs here, the evidence decision framework, is because they help us with coverage, health systems, diagnostics. So it's not really, it doesn't depend on the research question. Whatever the research question is, the ETDs can be used to work on developing a recommendation, and now we'll see on contextualization of recommendation. They help with informing judgments about pros and cons, to considering each important factor that determine a decision, including utilities, importance of a health outcome, providing a concise summary of the best available research evidence to inform judgments, structured discussion and identify disagreements, and making the basis for judgments and decisions transparent and adaptable for target audiences. And so with this introduction, for those who were not familiar with GRADE and ETDs, or this quick reminder of those, I'm not sure if someone else has access to the screen, but okay, now it's working. So here I bring you to how we are increasing the efficiency in guideline development. As I showed you before, very briefly, the guideline development process is long. It requires a lot of resources. It requires a lot of so human resources, but also financial resources. The last number I have on me dates back from before 2014, where one guideline would cost around $200,000 US dollars to develop. And so many other factors raised the attention that, can we actually answer a research question using work that has been done, using a guideline that has already been developed? And so the terminology adoption came from combining adoption, adaptation, and de novo syntheses. And adoption is where a recommendation already exists and all its factors apply to a certain context. Let's say the guideline was developed in South Africa, and I'm trying to work on it in Beirut, and I see that we have the same contextual factors regarding the specific intervention, population, comparison, and outcomes. And then in that case, I can take it as it is and implement this recommendation in Beirut. The next step would be adaptation, and that's where the context is different in certain criteria, and we will need to actually use local criteria, context-related criteria, evidence in order to feed into that criteria and build all over to construct a recommendation. And so adaptation is really taking into consideration any evidence that addresses the context. So for local implementation, adaptation is a place for that. And it also can follow the framework, the ETD framework as discussed before. And in the third case, when we don't have a recommendation that already exists and that answers the PICO question of interest, that's where we go to de novo synthesis. And that's why the combination of development can also refer to using all three, and that's where we're addressing a whole guideline. We're trying to contextualize a whole guideline where some of the recommendations apply as is, and that's we use adoption. Others will need to be contextualized, adaptation, and where there is no answer, we go to de novo synthesis. And again, just to put it in context, adoption will cost much less than de novo synthesis. Adaptation will cost somewhere in between. Context relevant is mainly when you actually are doing the adaptation. Adoption will not take into consideration context as we described, but de novo and adaptation would. De novo will take much more time than adaptation and more time than adoption. Adaptation and adoption are affected by the availability of guidelines, and de novo is affected by availability of evidence, of course. And adaptation might, there might be some modification of the PICO, but it's mainly when we do not have any answers to a specific PICO question that we seek de novo synthesis.
I think any patient who has completed the loading dose.
And so just quickly, the grade development process, 8 main elements: the general organization planning, defining groups and roles, selection of guideline topics, prioritizing questions for selected guidelines, using the grade evidence to decision framework, updating systematic reviews of health effects and identifying local data, preparing grade evidence tables and evidence to decision frameworks, and formulating and rating strength of recommendations. So I'll just ask the organizers to let me know if I still have time. I'm sorry, again, there is a lapse with the slides.
Hi, just to say, Tamara, it's all good. You've got another 10 minutes or so. We do hear one of your colleagues speaking in the background. I don't know if they know you're presenting, but okay, thanks.
Yeah, sure, but so I'll keep going, but the slides seem to be going very slow. Sorry about that. Okay, so to go through the advantages of a development here, we are building on something that already exists. This evidence synthesis base is, when the evidence synthesis is there, we can directly work on adapting, and when it doesn't, we'll have to go through more steps. It's a transparent process that considers factors with focus on local and regional setting. It helps in building capacity for the team that's going through the development process, and it goes by recommendation rather than by guideline. The challenges would be that the systematic review is required, but ideally ETD at starting point. So when another group has already developed the guideline and have constructed their evidence to decision framework, that would make it easier for a new group to contextualize and to develop a recommendation. It's challenging if existing SR restricted inclusion to certain study design, for example, RCTs or highly selected outcomes. And then when we're adapting, the questions might vary, or the contextual factors might accept a different study design. And then the reviews of other information those would be one of the challenges, again, if the context requires some extra information that the original guideline did not consider, the original recommendation. And last but not least, the panel will need to commit to follow rigorous methodological approach and stick to timelines, and that's one of the main challenges in adult. So our kind of solution to the urgency right now with COVID to contextualize COVID-19 guidelines was to first collaborate with a big number of researchers, guideline developers, evidence synthesis specialists, consumers, stakeholder engagement specialists globally from many countries across the world. And I see here at least 5 of our collaborators online and with us on this webinar, in order to build a repository, a catalog of all COVID-19 recommendations that have already been established and already published. This website is still not accessible for the general public because this is something that we just started working on. I'll be showing you mock-ups here, but as soon as we have it live, up and running, we'll make sure to disseminate it to all the attendees here. And so the purpose of this catalog is to make the recommendations available, accessible, and to present it in 2 ways where one, there's a map visual where you can access first all the populations that are in the x-axis or on the rows, and then the interventions in the y-axis, and that's in the columns, and see what kind of recommendations already exist. You have also, the users will also have the opportunity to filter based on their own question of interest, by age, by intended population, the intent of recommendation, which means whether it's diagnostic, whether it's screening, management, prevention, infection prevention, or health systems kind of question. And it helps us identify the gaps of recommendations. Additionally, it helps us find recommendations. So when a user identifies the population intervention of their interest, they click on the cell and they can see the recommendation that answers their question. As you see here, we repeat that this is only for demo purposes. And we've actually built these examples based on rapid reviews for COVID-19 that we've published in a collaboration between McMaster University and AUB. And users will be able to see that recommendation, but then also access information about that recommendation, such as the strength, the certainty of the evidence, the population, the intervention, the link to evidence to decision, the link to evidence syntheses, the evidence profiles, and much more. So what we're mainly focusing on is making all these recommendations that already exist available so that our decision makers globally don't have to waste time to find those. And for those wondering how we're finding these recommendations, we're building a very exhaustive search strategy. We have a team working on a pre-filtered automated search that we're validating in parallel with a manual search. And yes, we have the GIN library definitely as one of the libraries that we are covering. And additionally, the users will have access to evidence profiles that have been developed. For those who have not seen an evidence profile on GradePro before, it helps you see the recommendation, the background, the subgroup considerations, and the justification. And so what we will be doing is providing these evidence profiles when they exist. If they don't already exist, if the recommendation has been published without its ETD criteria and its evidence profile, we will be building those evidence profiles and constructing the evidence to decision frameworks. And we will be making sure all our platform is available in English and in French to try to be as to try to reach out to as many users as possible. And so, how are we integrating contextualization to this? Well, we're making the recommendations available. We're making it easy to find the recommendation, and then we're linking it to GradePro, where we usually develop guidelines by completing evidence to each of the evidence to decision framework criteria. And now we have a module that's added that says development, as you see, where you'll have the original recommendation, the original evidence for each criteria that has been used in the original recommendation that's published, and users will have the option to adopt, where they will, in case there's any change or any local evidence that says, you know, anything different than what was used in the original recommendation, then they could insert it in the development section and provide the reasons why you know, this recommendation has changed or this criteria is different, and most importantly, support it with local evidence. And so here, just to show you, users will be able to see right next to the summary of judgments for the original recommendation, the summary of judgments for the adopted work. And so they'll see where there was change that would be highlighted in yellow, and the importance of decision will also be there. And hopefully that will help users in making contextualization, making development easier and more flexible. And at the end, the recommendation will show, the original recommendation will show, and the users will be able to construct their adopted or contextualized recommendation. So that's it from my side, and I just want to thank Holger Schoenemann, who was also supposed to be helping with this presentation today, but he definitely contributed to the slides and to the flow of this work, and the McMaster team and all the collaborators on this project, and happy to take any comments or suggestions or questions. Thank you.
Thank you, Tamara. That's great. What an exciting database that you're sharing, and the possibility for many of us to lean on this rather than starting from scratch is really appealing. I see we have one question from Yasser, and thanks for that. It's about whether the database will be open access.
So the plan is for the database to be open access. That's the plan.
Okay, so no cost
Thank
barriers.
You,
and let's
no.
check if
So
there are any other.
Yeah, sorry. So just to explain, it will be freely accessible to any user. The only part that will not be accessible as soon as the user requires it is the development part, where it would just for the first few months and maybe a year, it will require contact with us in the background so that we facilitate the process. But otherwise, any information on the platform is definitely available and accessible for free to anyone.
Excellent. Great. I don't see any more questions at the moment, so I'll shortly be handing over, but thank you, Tamara, and stay on the line for any other questions that come through. Thanks a million. So I'm going to invite Dr. Ajibola Watiwan to join us now, and I will hand over the slides to you. Hang on one moment, I'm just doing that. Ajibola, over to you.
Thank you, Tamara, for that. Thank you to all the other panelists and all the attendees that made time to come on this session. I am Ajibola Aotiwa, and I'll be presenting in place of Professor Lara Farrell, who is the founder and the head of the Knowledge Translation Unit of the University of Cape Town. And we will be discussing the lessons learned in implementing COVID-19 guidance in LMICs. And I say discussing because some of my colleagues from the Knowledge Translation Unit, as well as colleagues from the in-country partnerships, are also present on this webinar so they can contribute their experience of implementing COVID-19 guidance. So over the last 20 years, the Knowledge Translation Unit has developed and tested, refined a health system improvement program designed to support the work of primary healthcare workers in low and middle income settings. And we have been trying to strengthen the health services in which they work and thereby achieve the best possible patient outcomes. The practical approach to care kit program consists of a clinical decision support, which is policy aligned, comprehensive guide that is arranged in algorithmic and checklist formats. And these guide is implemented. The implementation of this guide involves on-site team-based training model. Next. Okay, go back one. Get the slide to go back on. Yes. The PAC program has been evaluated in several pragmatic trials and has shown modest improvements in appropriate prescribing, referral of severe cases, and important health outcomes like mortality, CD4 count gains, among others. And while these findings have been part of our South African work, there has been a recently published trial in Brazil which showed positive outcomes for respiratory illnesses. So before COVID, we had been working through a partnership with the British Medical Journal in a range of low to middle income settings, including Brazil, Ethiopia, and Nigeria. And in each of these settings, we've mentored in-country stakeholders to localize the PAC program and tackle the health system issues that this localization surfaces. And each localization has had some variation in response to local resources, timeframes, and funding models. And just on the slide there, you would see the top left corner is it shows the snapshot of the Brazil localization, which took about 18 months to complete. The Nigeria localization, which is in the bottom left there, took about 6 months to complete, and the Ethiopian localization that's in the middle there was completed in about 3 months. So it's the time frames have varied in terms of the resources available and other factors as well. So what have we been up to during COVID? So since the start of COVID, we've focused on creating guidance for primary care setting because we were concerned about the overly hospital-centric approaches that were in the guides that were available from the high-income countries. And we were concerned that these hospital-centric approaches would not be sustainable or even viable for many of the low-income countries in which we reside and work in. So we focused on primary care guidance, and we were responding to an urgent need to provide clinical guidance for primary care clinicians in Western Cape. And that was where it started. That was one of the first guidance that we created. And you would see from the top left corner here, the guidance that we created for the Western Cape, which is a province in South Africa. And to create this guidance, we had to comply with the provincial and national policies in order to reflect what should happen at this level. And then this guidance was adjusted to comply with just national policies, and we were able to produce a guidance that can be used across the country of South Africa. Now, we were able to take this guidance that was being used in South Africa and align primarily to WHO guidance in order to create a global template that any country could take on and use. And this is what we were able to provide for countries like Brazil and Ethiopia to take and localize to their setting. Now, these global versions, which we shared on our website, are in an editable format so that it's easily adapted for any interested groups. And as I've said before, it's been localized and used by colleagues in Brazil and Ethiopia. I've tried to capture snapshots of the guide. This is the Brazil guide. It's in Portuguese, obviously, and this is the Ethiopia guide as well. So in terms of training, as I said before, we've always used a team-based, case-based on-site training model. But with the pandemic and the need to conform to new social distancing norms, we've had to change our on-site training approach. And this has meant that as we've created clinical guidance, we've had to also produce online courses that go alongside this clinical guidance. And some of these online courses you would see on the slide. This is for the online course that goes with the Western Cape guide for the Western Cape province in South Africa. This is another online course, but it's mainly focused on PPE and management of health worker exposure and occupational stress. This other third course here, which I've showcased, is the one that goes with the global guide. And how this would typically work is that the health worker can go onto this platform, the KTU Online School Thinkific platform, and register and be able to access these courses and download the materials and the course through the quiz and the case-based format would help the user navigate the clinical guide, and this helps them to get to be informed about what to do in the different clinical scenarios. Now, we've been successful with this online training model with the Western Cape data-free access model, but given the internet challenges that are common in most low-income settings, we're still unsure about how they would be used. And maybe later my Ethiopian colleague who's on the call might speak to how they've been able to use what training model is being used for their implementation, because these internet challenges are everywhere. Now, the last batch of content that we've pulled together during this pandemic is content that deals with community messaging, and we've pulled together quite a lot of content on this. I've just pulled out the content that shows the breadth of what we've covered, but there's quite a lot more that can be accessed on our website. So we've created content on basics of good hygiene. We've produced content on environmental cleaning, on traveling safely, shopping safely, staying safe in the workplace and at school. And several of these community messaging content has been translated into 5 of the 11 South African languages. So while it's been difficult to practice best practice in implementing clinical guidance during the pandemic, this has allowed us to gain some insights, and I would go through some of the lessons that as we've learned. So the first one I'll go through is just speaks to the lack of resource-aware guidance, and I will just pick two aspects of this, which is the testing and the oxygen availability. We've always known that most health facilities in low-income settings are going to struggle in terms of providing oxygen for their patients, and as the clinical guidance have been produced, as we've seen the international guidance come out, WHO guidance and the rest, we've seen a dependence on oxygen for the management, and there hasn't been an alternative. And it's in being able to provide clinical decision support that the primary healthcare worker can use to decide how to manage the patient. We struggle to find evidence, struggle to find guidance to help the primary healthcare worker to decide what to do in situations where there is no oxygen available for in that facility, which I don't think is as rare as I think it's a quite common occurrence. Now, the other one that I'll speak about is around testing, and the guidance that we've been coming across and we've been including as part of our materials have mostly recommended universal testing, and it was when we've and that's testing of every person that meets the criteria for that meets the criteria for testing for the virus. So but as we've seen the demand for testing outstrip supply, the move to selective testing hasn't been as uniform or as smooth as we've expected, and we haven't seen a lot of guidance on what to do in terms of selective testing. And you would see, if you we've kept a close eye on the latest WHO guidance that's been produced week in, week out, and this selective testing hasn't really been a focus of most guideline recommendations, and it maybe several paragraphs of the guide, and it's something that it's going to be very relevant for the low income setting, but it's not being addressed. And even in the setting where there's actually no testing available, like what do you do then? You identify the person as a probable case, but then you can't really use every possible you can't use the same recommendations for the confirmed patient as you would for the probable. And how many times are you going to isolate someone, a probable case, and unless you can actually test the person to see if the person has the virus? So that was one of the learnings we had. The second one, which I would go through, is the lack of when we use the guideline constructs to resolve impasses in certain recommendations. And speaking to this, we've over the years, as we've worked on clinical guidelines and implementing them, we've noted a lack of convergence in a lot of guideline recommendations, and it's pretty commonplace. But with the plethora of guidance that's been published on certain topics on this pandemic, we've realized that the lack of convergence has become quite exaggerated, and we've seen different recommendations coming from different sources. And one example I wanted to highlight was in the guidance for the management of the dead body in the context of COVID-19. A big part of the problem was the hangover effect of a previous pandemic, which was the Ebola pandemic, and the concern of transmission and not really knowing if transmission was a problem or not in terms of in how the dead bodies are handled. And we needed to use knowledge translation as a form of mediation between different stakeholders. And the construct I'm referring to is being able to minimize cognitive dissonance, presenting information in a manner that it doesn't create conflicting beliefs, and it doesn't create the impression that the recommendations that were produced are substandard, but just helps all the stakeholders realize that you need to develop a solution that could be communicated to the frontline health staff, and everybody would ultimately be on the same page. Now, the last two learnings I will discuss are relating to relationships and capacity. And as we've been developing implementing global guidance for COVID, it's been possible to leverage off some of the networks that we've established with in-country partners prior to the pandemic to support the response. And we've seen that in settings where we've established quite a good relationship and been able to sort of capacitate the in-country teams, there have been a swift uptake, adaptation, and implementation of the clinical guidance. And but we've seen that in countries where, in more recent networks, that we haven't been able to build the typical KTU localizing team relationships because of the travel restrictions. We've not seen the same level of implementation. And this relationship building exercise usually happen over team visits, which typically provide opportunities to workshop challenging localization issues together, and it helps to facilitate the localizing team participation in PAC training. So that disparity might point to the fact that that knowledge translation really is very relational in its core, and we might need to pay more attention into developing relationships and capacity so that when the next, if we have to endure to another pandemic, we would have that in place to drive implementation. So the last point I would discuss is it refers to reciprocity of these relationships. And one example I would cite is the Brazilian work that we've done. And what we've noted is that when we following our adaptation of the WHO guidance and following their localization of the guide, we've seen that their input has helped to clarify, shape the evolution of the COVID-19 screening approach that is depicted in our guides. And this reciprocity has been something that we've seen repeatedly in the localizations of our guide. And we've seen, it seems that our mentorship model seems to lend itself to a reciprocal phenomenon that allows for teams that have localized the guide to also impact the global guide and help to improve it in the process. So to conclude, adapting and implementing global guidance in a pandemic can be quite challenging, and it's by being open to working with different stakeholders to help facilitate a compromise and utilizing established networks to drive implementation across borders can make a difference. I will just end with this slide. I think I've gone past it. This slide, which shows a snapshot of our web page, where you can find, you can have access to all our global resources and access all the community content as well. There were so many, I couldn't put everything on this slide. Thank you very much.
Thank you very much. Thanks so much, Ajibola. I think you've showcased a wealth of work that's been happening, and I'm just looking out for any hands or if we'll hold over for discussion later. I don't see any questions at the moment, but just to thank you for showing and showcasing the wealth of approaches and also your kind of very hands-on experience with these team-based localizations, as you call it, or contextualization of guidelines from one place to another. And I think there's a lot we can learn from there and hopefully discuss. I did want to, thanks Patrick, thanks for joining. I just wanted to, I know you have your colleagues from Ethiopia on the line, so I'm hoping that when it comes to discussion time, we can also ask them to just give comment verbally. We'll unmute and give people a chance to speak. Thank you, Ajibola. I'm going to move on and invite Patrick up to speak. I'll just put him on the right slide and I'll just switch myself off. Hang on.
Okay, thank you very much, Tamara, for handing over to me, and thanks to the previous participants. You've given some great talks, and I'll follow through with our experiences from the Gene African community, what we've been doing, what challenges we've faced, and how we've coped with them. Just as a word of warning, I'm actually calling in from Bamenda, Cameroon, where conflict and COVID is really affecting the way we work. We've actually been for a week now without electricity, and I'm just working for this webinar with the solar panel I just installed, and I'm hoping that it will be able to see me through the presentation. If I go off for a minute, if I go off, I'll be back in a minute. It happens very commonly, even within this webinar as we started. I would also like to say that I'll be throwing in some links and some questions in the chat box. So please feel free to contribute when I ask ask for your help in these kind of contributions, because this will help to keep you connected to the presenters, to the webinar. Okay, so generally, I will be talking about Gene Africa experiences, and this will include the Gene Africa community and opportunities that exist within Gene, which may be more than most people see. I'll also be talking a little bit about clinical practice in Africa, about indigenous research and policy influence, about some challenges, some opportunities, and how we've been engaging consumers. I'll also be talking about evidence hesitancy, which is a concept that we were reporting before COVID, but which is even more significant within COVID and the fake news era. Then I'll also be talking about transferability of recommendation, which is also one of our baby concepts that we are doing at eBase Africa. Let me see. Okay, so Gene Africa community was an idea that we started floating in 2014 at the Gene 2014 conference that held in Melbourne, and quite a few people on this webinar were actually actively involved from the beginning, including Tamara and Sue Huxon from Australia. The current membership is from 8 different countries, including 18 individual members and 2 organizational members. And the link to see the activities of Gene and how you could be a member, I have also just posted in the chat, which you could follow through to join or to become a member. Now, it's become a very vibrant community in recent years, especially with the under the chairmanship of Nga Etienne, who took over from me this year. And we've started initiatives to lead guidelines activities, especially in Middle Africa. And we also seek a lot to exploit opportunities within the Gene networks. This is actually a golden opportunity that most people fail to notice, because in networks, people may be looking out at what do I gain from this network? But we found out that actually within the network, it's easy for you to piggyback on other organizations that maybe have enough funding and need someone with good capacity. And we may have the capacity, but maybe not the funding. So we can piggyback on guideline projects that are ongoing, and then we can contribute from our context. And those guidelines in the end will be guidelines that can be easily used within our communities. This is one of the really strong points within Gene from the experiences of most of the members within the community. For clinical practice in Africa, just as Joseph mentioned earlier, clinical practice is very diverse. And even within the African context, there's also a lot of diversity. You have the northern parts of Africa, the middle parts of Africa, and then the southern parts of Africa. Mostly the northern parts of Africa, where there is the government will to invest in developing clinical practice guidelines, but the funding may be little, but it's also available. Then you have Middle Africa, which is mostly Sub-Saharan Africa, where the government is actually faced with so many challenges that they actually are unable to catch up with needs to develop clinical practice guidelines. And it would be interesting to actually note that members from this community are actually very active in the global community for developing guidelines. But for high income countries, like for South Africa, for Europe, for the United States, you have people who come from Middle Africa, and who may not exactly be providing the kind of resources that they could have done for their country. So in the chat box, I've actually I'm asking the Sub-Saharan African experts who are within this webinar at the moment to maybe you tell me I have or I have not. If you are within the webinar and you've actually been able to actively contribute to developing guidelines for a Sub-Saharan country, it would be interesting for me to gather these kind of options at the end of the session. and this will also keep you active or engaged in the discussions. Then you also have South Africa, which has its own context that is very, very diverse. Within South Africa, you would have communities that are typical or similar to a lot of what we have in Middle Africa, where there is inequity, wide poverty gaps, and things like that. But it is a country where there is quite some commitment to developing clinical practice guidelines. Now, the major steps that we've been able to make within the Gene African community has been as a result of promotions from network partners or network members like the Cochrane Collaboration, Joanna Briggs Institute, and the Africa Evidence Network. Lots of evidence has been synthesized, lots of recommendations have been made, guidelines have been developed, adapted, contextualized, transferred, but we still have one big challenge, which is access to technology. A systematic review from Cochrane recommends that we should use blood culture for testing of typhoid, for example. But at district level, for most of the clinical practice settings in Middle Africa, the doctors will not be able to perform a blood culture. And even if they perform the blood culture, the cost may be too high for most of the people to be able to afford. So access to health technology is a challenge. And then another challenge, another characteristics of clinical practice is conflict. And now conflict and COVID, which gives a recipe for a perfect storm. So most Middle African countries, for example, have conflict, and then COVID has come in, and then the clinical practice setting is even much more complicated. When we look at, okay, I don't know what's happening now to the slides. I think it seemed to have skipped by itself. Tamara, I'm not sure if I still have control over the slides. Okay, I think I have it again. Okay, so most Middle African countries, for example, have adopted the use of hydrochloroquine for the treatment of, for the management of COVID-19. Cameroon, for example, this is standard practice, despite the fact that we don't have strong evidence yet. We don't have evidence yet for its effectiveness, but this is being used. And the reason why this is being done is that most of these countries may not even be able to afford the oxygen machines or the other health technologies that you will need to rehabilitate the patients. And they live in very fragile political settings, and they need to give something immediately to their citizens. And so what they would quickly jump on is something like hydrochloroquine. And that has been the case in Cameroon, for example. Then now I would also like to have a little look at the leadership expectations for Africans who are active in the evidence ecosystem, be it primary research, evidence synthesis, evidence translation, or evidence implementation. Now, indigenous research is still weak and faces major funding challenges for COVID-19 in particular. Generally, for other conditions, African leadership has been quite strong, even though it is still lagging behind when it comes to funding and funding from their own setting. Competition for funding is not a level playground. I mean, if you look at most of the research calls that go out there, even for research that is, or guideline development or evidence synthesis that's meant for Africa, you find out that most of the time for you to be able to compete, you will need to partner with a university in the north, or a university in the north looks for a partner in Middle Africa to partner with them to move on. And sometimes the big question there is always, who calls the shots? Who decides on the PICO? Does the patient who is at district level in Bamenda, for example, is that patient able to contribute in developing the outcomes or the interventions, or especially the outcomes of interest? So these are some of the questions that come into play when you start looking at how do we get funding. Now, leadership programs have been very encouraging. Recently, We have the Cochrane Obresheham Awards, the AEN Leaders Award, the African Academy of Science Awards, the EEF Global Fellowship Awards. So these are awards that are stimulating leaders who are coming up with concepts from Middle Africa itself, and who are building an evidence experiment and experiment provides an opportunity to learn for other pandemics. Okay. There is quite some lag in the movement there, mostly because of the, I'm sure because of the internet speed.
Patrick, I'll hand it back to you. It came back my way. But just note, we only have a few more minutes remaining. Over to you. Colleagues, it looks like we might be having a connection problem with Patrick for the remainder of his, at the moment. So I'm not hearing him. Alison or Sarah, or any of you? Ah, there you are. Okay. I hand back to you, Patrick. Just to mention, just a couple of minutes remaining. So colleagues, we may have lost, there you are. Okay, try again. Just to wrap up in the next couple of minutes.
I think I'm back online now.
Yes.
So there are serious challenges with social distancing and affordability of masks in Africa, and the question has always been in areas where people live in slums, where living from their houses to anywhere they have to. And if they have to stay at home, how would you ensure that they are able to have food to eat on a daily basis? These are the challenges that we have. Then the issue of fake news and evidence hesitancy is really strong. And this is another combination that was very, that created another perfect storm within the COVID-19 setting, where we have fake news that tells people that don't look at what researchers are saying. It's all an agenda by the WHO. It's all an agenda by Bill Gates. So this makes people to be more hesitant of evidence. I have also just posted a question in the comment section for you to look at. I think I don't have control at the moment. Again, if I can get control, I'll move on to the next slide. But there's a chat in the comment which is asking the global community if you will be ready to include an expert or a stakeholder from the LMIC setting if you were developing a guideline in, say, a high-income country, and how this could make the guidelines more global and more useful even to LMIC settings. I'll be interested in knowing if we have participants from high-income countries who would be ready to do this, for example. Now, and when evidence is available, we always ask a number of questions. FA, F for feasibility, M for meaningfulness, and E for effectiveness. And okay, that's moving quite fast. Sarah seems to have control at the moment. And these are questions that we have asked ourselves every time we see a recommendation that we want to use in clinical practice in LMIC. And is it feasible for our setting? Is it appropriate for our setting? What does it mean for our setting? And of course, the effectiveness tends to be general. Let me see. I think I have control now. Okay. So,
Patrick, just to let you know, we only have a few minutes left and we still want to have a little bit of discussion. So we do have to ask you to wrap up your slides over here.
Okay then. All right. So we can run to the end now. Okay. Okay, so I would just like to quickly talk about the E-based transferability model. So this is a model that we are developing and that uses characteristics of studies used to develop practice and policy recommendations to predict if guidelines are transferable to our setting. And it's actually receiving funding from the CEDIL program and EEF UK. And it has 18 sub-variables that are packed behind 5 main variables, which include cost, relevance, complexity, effect size, and the importance to stakeholder. Now, the idea behind the transferability model is just that it can predict if a guideline that was developed maybe in the UK could be applicable to a country in Africa, like in Cameroon or in Niger, or a guideline that was developed in Cameroon, if it could predict if this could be useful in the UK. There's a lot behind it. We use a lot of predictability models to tell. Then I'll also quickly flash about some of the collaborations that we are doing, which includes the Gene Resources, the Gene COVID Task Force. JBI is also currently supporting 2 major projects in Cameroon and in Kenya for evidence implementation. And you could actually find more about this in joannabriggs.org/COVID-19. There's also the COVID-N and the EBM Africa Network. We have our lab now. And I would also like to finally talk about, these are some publications that we've been able to make from the Gene Africa community. Response to the novel coronavirus pandemic across Africa, where we've had actors from many different countries in Africa that are active in developing, in research, participate. Then the position statement from Gene Africa, which is on the Gene website, and also the rehabilitation of patients with COVID-19 in African settings, which was also developed in collaborations with partners from Canada. Then I think we have lots of perspectives that we could be looking at, collaborative projects with LMIC members, evidence leadership programs, and doing it right for COVID allows subsequent capacity to address other local pandemics. Because especially in Africa, we have seen quite a lot of pandemics in the past. The COVID-19 pandemic is just hitting the world, and it's actually taking a lot of people by shock. And the African countries are a little bit more resilient to this. So, thank you.
Patrick, thank you. You covered a breadth of information there and shared a lot about the networks in the region, in the African region. So thank you very, very much for that. I'll invite all of the speakers to come back on board just to acknowledge everyone that's participated and contributed. I know there are a few questions, and thanks to my colleagues who are responding to those questions. And thanks to colleagues at the Knowledge Translation Unit who've shared a link to the website. I just want to check if there are any, we've covered a lot of the context that Joseph was able to cover for us, information about an development project that Tamara and colleagues are leading, the work that Ajibola and others have kicked into action during COVID, over and above their normal work to provide localized guidance for many countries, available as a template for others to use, and then Patrick's experience with working with various networks in LMIC settings and the work specifically in Africa. So maybe, given that our time is unfortunately up, I just have to take this moment to thank everyone for their participation in this fantastic webinar today, to thank the organizers at GIN, and also particularly to thank all of the participants who've taken the time to be here and listen in, and just to invite you to you've met all of us virtually. If you want to reach out and ask further questions, please be in touch. We would like to hear from you. And thanks particularly to GIN for hosting this webinar and making it possible. So thank you very much.